During this session, we will take an outreaching view of the critical scientific developments in the TBD field as a whole over the past few years.
Okay, can you hear me?
Yes.
Okay. So, well, thank you for the invitation. I'm honored to be here. I'm going to give a couple of housekeeping advices here. So, we're going to change gears a little bit. This is, my presentation is going to focus more on what we call preclinical results or things that are being researched now, but they are still not, let's say, ready to prime time, so it's not ready to be used in the clinic. I just wanted to give you an overview of specific things that have been developed in the last 3-4 years, that could be promising for in the future develop new methods of maybe diagnose TBD or even treatment in the future, right? So I'm going to just present another work that has been published. There are some other work that is still not published that I'm not going to touch on, but you'll see most of these papers have been published with people who are actually in the room, so they probably can chip in if they need it. So, well, that said, so I'm going to touch on this main aspect. The field of research in telomeres in general is very broad, so it's not really, this is from basic biology to applied biology, as you have seen, and clinical trials. So, I'm just going to touch base on kind of what is in between those. First, I'm going to start talking about some new developments in novel diagnostics tools that have been used. So this is a busy slide, but I just want to highlight there are several methods that have been developed to measure telomere length, not only in the clinic but also in the research phases. The one that is, of course, you're more familiar with is the flowfish. This is the one that came up several times. This is the only one that is now being used in the clinic, so the only one that can actually be used to do a clinical diagnosis. And you can see that's the use of these are reference values that have been published and you're all familiar with, using the telomeres over, get shortened over time. But one thing that I want to highlight is that this method, what they provide is the average telomere length of the cells. So what do I mean with that? So when you look at our whole genome, or karyotype, all the chromosomes that we have 23 pairs of chromosomes, so you get one set from your father, one set from your mother. So we have in total 46 genes, chromosomes, and each one of them have 2 telomeres by themselves. That means that there are actually 92 unique telomeres. So when we measure by flowfish or any other techniques I mentioned, what you get is the average of each one of these telomere lengths for all the chromosomes, right? That is very valuable, don't get me wrong, this is actually something that has changed how we approach these diseases. But right now, there's been some methodology that can actually look at the length of each one of these telomere lengths specifically. So, as I said, there have been several approaches, and this is kind of, at least in the biology, again in the research part, there has been some indication that it could be actually a specific short telomere. So the first one of those 92, let's say, that gets shortened, which can actually be clinically relevant, right? Although the average is also relevant, as I mentioned, but there could be other things that, looking at the chromosome-specific level, we can get more information about what's going on. And there's, at least not in the TBD yet, but there's some indications on, again, everything published in the research realm that indicate that some of the chromosome arms, specific chromosome arms, can be actually involved in some other diseases. So, as I mentioned, there have been several methodologies to look at this. One is what is called high-throughput stela, which is basically a technique where you can look at each one of these values in specific chromosome. This is looking at just chromosome 17p, which is the small arm of the chromosome 17. And it has been seen that it could have some diagnostic value. As you can see, this is the controls, and this is individuals with different variants in these genes, and they get shortened. Another approach that has been recently, it's kind of gaining more attention now, at least more in the research, is it's using what is called like next generation sequencing technology. So you all, I assume, have had any kind of genetic testing at some point. Some of you probably have had what we call a gene panel. So basically what we do is, this is a method that you can look at different genes, sometimes even the whole exome or the whole genome at the same time, right? So the technology that is more extended is what we call short-read technology. So basically that works, so you take your genome, you fragment it in small pieces, which is this, and then you basically map that to a reference genome. So we know the human genome, which is reference, which is here, and then you can basically map all of that there. The problem with this technology is that if you have a sequence like the telomeres, which is very repetitive, so it's the same 6 letters all over again, which is PTA, GGG, PTA, GGG, PTA, GGG, etc. So you cannot measure with this short technology, you cannot map these telomeres to a specific chromosome. So that has changed more recently because it has been developed a new technology that is called long-read sequence. So it's the same process, but now instead of having a small fragment, you have a long fragment that you can actually map much longer areas. So the basic principle is that, okay, we have, let's say, chromosome 1, chromosome 2. You can see that each one of the chromosomes have their specific sequence, and then this will be the telomeres. You can see the sequence always the same, being repeated, right? So if you have a small fragment, let's say that's just TBDs, then you don't know if this is here, or here, or here, or here, so you cannot map it to a specific chromosome. But with long-read, what you can do is now map, basically you can sequence you can map the TBDs, as well as some of the region of the chromosome that is specific for that chromosome arm, okay? So using that, now we can measure, and this is one method that we developed a year ago or so, is that now you can see specifically for each one of the chromosomes, where is the telomere length. As you can see, this is a non-TBD individual. As you can see that even in a let's say, healthy population, well, healthy is a weird term, but you see that there's a lot of variability in the different chromosomes, right? Not only that, these are, so as I mentioned, we have a pair of chromosomes from the father, a pair of chromosomes from the mother. Even between those two cell pairs, there's variability. This is the chromosome 6q, and you can see, this is the same individual. You can see that even between the same individual, there's a lot of variability on the telomere length on them. Now, all the effort that have been done now is that to develop this technology, but we still don't know what is the biological meaning of this. So now we have the tool to look into that, but we still don't know. So that's why I mentioned that this is still very preclinical. So the effort now is to actually study this and see what is the significance of this. For example, one hypothesis could be, well, are specific chromosomes, specific telomere length in a specific chromosome involved in, let's say, for example, the variability of the phenotype that we see. So why individuals will have the same mutations, some of them develop one phenotype and others develop a different one, right? So not only that, it will also have meaning about, for cancer. So once the chromosome is getting shorter, could that actually predict what kind of cancer can you have, right? So all these are questions that now with this technology we can answer a bit better, right? So hopefully next time that I talk with you, actually we have more data about how this means for a TBD individual. Then another thing that is I wanted to highlight about, and actually links with the cancer talk that Dr. Shaba gave like an hour ago. Another thing that we're being interested, that has been a kind of a new development, is that the individual with TBD have an increased amount and a specific pattern of what we call clonal hematopoiesis. So clonal hematopoiesis means that it's these small mutations that you get. So this is the bone marrow cells, the stem cells over time, okay? So each one of these dots represents a different mutation. So these are called somatic mutation, and they are basically, we acquire that as part of, just being in the sun or just living, you just get these mutations somatically. Most of them don't have much meaning, and they just basically, disappear over time, and you get it, but they don't have any kind of, impact in your health. But some of them, what they do is they give a clonal advantage. So what that means is that the cells with that mutation start expanding more and more, and they keep growing. And then they can acquire additional mutations, and again, this mutation over time keep accumulating, and that could be actually the first step to evolve into MDS or AML, so leukemia or these symptoms that Dr. Shabbat mentioned before. So a lot of effort now are being done to actually detect this mutation at a very early stage before they actually evolve into that. I have to say this mutation can impact different genes, and depending on which gene is impacted and at what point of life. Okay. I was hitting a high pitch. Were you hearing that? Okay, I'm not quite crazy. So then those mutations, actually, as you can see, these are non-TBD individuals, but they increase with age, okay? After the age of 60 or 70s, so almost, around 20-30% of the population have these mutations, just normal. What we have seen, we and others have seen that in the case of TBD patients, there are more of these mutations, and they impact different genes than the one that you see related to aging. Okay, so that means that there have to be something specific about the TBD that could have some clinical significance. So a lot of effort that's being doing now is just to see, first of all, detect these variants. Actually, Chris Rayleigh, who was here this morning, he's also working in this space, and we're trying to identify these variants specific for TBD, and what is the meaning, how they evolve in the context of TBD, just to see if we can kind of assess, using this mutation, which patient is at higher risk of developing cancer down the line. So that what has been observed is that in the case of TBD, this mutation can come in two main buckets. So one is what we call adaptive. So basically, it's a mutation in the promoter of TERT. At this point, you probably know, everyone knows what TERT is, but it's the gene that codes for the telomerase, which is the main protein that elongates the telomere. So some of these mutations have been seen that affect genes in a way that correct, in a way, the germline effect. So basically, the mutation that you were born causing TBD, and those generally is considered to have a low risk of MDS/AML. But then there are other mutations that are associated with this clonal hematopoiesis I was mentioning before, that are impacting leukemia-associated genes. So what that do is they give these cells a clonal advantage, but they don't correct the germline defect, so the original defect. So that means that by other means, so the cells start expanding, but since it's not correcting the defect, the risk of MDS/AML we think is higher, but we have to work. That's kind of what we're exploring. So this, more or less, the main hypothesis is that so if you start with a bone marrow cells with short telomeres that have, they cannot expand. So the y-axis means like the capacity of that cells to expand, let's say. So if you get this mutation, then that can actually correct at first the phenotype, and you can have higher blood cell count, but eventually that can keep going and then can lead to cancer. So this is the hypothesis we're currently working on, but we are kind of studying that. So hopefully in the future, once we know more, we can do this test, and then we can see, before you evolve into cancer, we can say, okay, well, you have this mutation, this has low risk of evolving into cancer, so we just have to check you out, but you don't need to do anything differently right now. And the other case, if you find this mutation, this has high risk, so maybe, we have to consider other options, right? But we're studying that right now. I'm going too fast, maybe, so just let me know if you have any questions, but if not, I'm just going to keep talking. Then I'm just going to touch very briefly in the expanded clinical manifestation that have been seen in TBD. I have to, again, I'm in the lab, I'm not a physician, I don't see patient directly, but what I can say, this is a summary from Dr. Savage, actually, one of the current reviews. You can see, this is nothing new, that means that, TBDs are very broad, very variable. There's a lot of different phenotypes, a lot of different age of onset, genes, so it's a little messy, but that's what it is. So yes, again, the main idea of this slide is that there has been what's called a classic feature of TBD, of course, like splastic name. I mean, I'm not saying anything new, we've been hearing about this for the last 3 days. But then, in the last 5 years or so, there have been a lot of new additional phenotypes that have been described with TBD. So, again, not all TBD patients are going to develop this. This have a lot of variability and a lot of causality, but the main idea of this is that the phenotype is keep expanding, and this also link a little bit. I'm going to try to speak quieter. This actually links a little bit with the advocacy, I would say, presentation that we saw this morning as well, because when you reach out to a physician, I assume that not all of them are going to be up to date to all the last phenotypes and everything. So having this in mind would be also good to identify more TBD patients. And then last thing is I'm going to talk a little bit on treatments option that have been. Again, I want to repeat, this is all for the clinical studies, so hopefully this will evolve into more treatments for TBD patients, but it's not nothing that you should go to your physician asking for this. You know what I mean? It's more like, this is what we're still doing. It's promising. Actually, a lot of this is being developed by Dr. Agarwal also here. So, and we are hoping to move into clinical tests very soon, but this is not there yet, okay? Now, that said, well, danazol, yes, so of course, danazol, I just put in this as an introduction, and again, I'm not going to stop much here. We already talked about danazol for the last couple of days, so I'm just going to move to other options. So, one of them that is showing very promising results is, so it's called the small molecule PABD5 inhibitor. So, PABD5 is a protein that is involved in the TERT regulation. So TERT is there's TERT and there's TERT. So TERT is the protein part, TERT is the nucleic acid part, so basically another component of the telomerase. So PABD5 is involved in the regulation of this TERT. So what it has been seen is that with using a small inhibitor of that protein, then the telomeres of individuals with mutation can actually increase over time. And this has been shown in vitro, in patient stem cell, but hasn't been tested in patients yet, right? Then there are other options. This is from a group, I think, from Italy, that they saw that using, so basically it's a protein called TGS1 that is also involved in TERT maturation, and they've seen that inhibiting that can also elongate the telomeres. And then this is another treatment also by Sunit. So, as I mentioned, the telomeres have like the same sequence all over again. So TTAGG, so TTAGG are the different letters of the genome, cytosine, guanine, and thymine. So the T, which stands for thymine, is one of these components. And then what Sunit's group has seen is that by just adding or providing this thymine, which is one of the letters that is needed to create the telomeres, you can see that this elongation. So basically, you see this kind of this curve going up, the log going up a little bit. So that means that the telomeres are getting elongated. But then once you remove the thymine, actually, this kind of stay normal. And then this is basically this, but quantified. You can see that the telomeres that are treated are again short, but then when you add the thymine, then you see an elongation, right? So this could be actually another way that you can control telomere length, and this is the pathway that goes from the DT, so creating this kind of, each one of these individual letters. So basically controlling this pathway, which is the pathway that you can, that the cells follow to create these letters, you can control with the telomerase activity and the telomere synthesis. Okay, so again, this is something that basically just playing around with this or inhibiting one of these steps or increasing one of the others, then you can control the amount of timing that is available to the cells, and then that will control actually how much telomeres are created, roughly. Again, something that is very promising, but we'll need to then look in a clinical context, right? And then just to finalize, I mean, just some future purposes. So what do we expect to see in the next, couple of years or 2 or 3 years? So I just put this touch point here, just hopefully to start a conversation. But the idea is that, well, as I mentioned, there's a change in phenotype that is being described all the time. So we need to increase the awareness of TBD, and that's what you all guys are doing. And then, so everyone is up to date about very different clinical manifestation research advances in this field. Also, I mentioned that there are probably more genes that are involved in telomere regulation that we don't know yet. There are still a lot of individuals with TBD that we know that they have because they have short telomeres that we cannot identify what is the mutation leading to it, so more research would identify new genes. And then again, just a lot of this clinical, a lot of this treatment that I mentioned, I mean, they have to move into clinical trials before they can, get to you, and that what we expect to do in the future. And this is just a little bit just for myself. So I myself, as you say, I'm Hispanic, so I'm working with some collaborators, for example, in Mexico or Spain, and then we are kind of saying, and this is not limited to TBD, this is every genetic, any disease in general. I mean, most of these studies are all like, Caucasian males, let's say. But, so that means that but there's a lot of variability this have been shown, and we need to, I think that there's now more awareness. At least I know that in Mexico now they're going to open one of the first TBD clinics there there. So hopefully with that will give us also, more awareness of the different ethnic groups and how these telomeres are different between groups. And actually, this will also benefit everyone in general because let's say that we find a mutation in a gene and we don't know what the mutation do, but if we see that that mutation is common in other ethnicities, maybe that means that the mutation is not that pathogenic, right? So I mean, it will benefit everyone, but that's more or less what I have. So again, I want to be fast and overview, but I'm happy to take any questions now. So again, thank you.